And I'd like to add that I'm from Argentina, from Buenos Aires. Now I'm in Buenos Aires. I'm so sorry I cannot speak Portuguese, in spite of having so many colleagues and friends in Brazil. I cannot speak Portuguese. I'm a disaster really with languages. So I'm sorry about that. But well, let's see how this is going. It's really a pleasure to be here with all of you. So the idea is to share with you some concepts related to implementation science, and the concept of complexity that we deal with when working in implementation science. Also some tools that we use. And in case you have any question or comment, please just interrupt me and ask your questions or comments, or maybe you can share experiences that you have as well. So feel free to interrupt me at any moment. Now I will share my screen. I have the idea is that we will go through a first presentation now, then we'll make a brief break. Renan said a coffee break, so I can make some coffee for me as well, and then we will go into the second part of the lecture or class. Well, so let's start with this outline I prepared. First, I'd like to review together what is actually implementation science and why is it so important. Then we can go into the concept of complexity, which you know that is part and parcel of implementation science always. And related to this complexity, we will talk a bit about complex interventions, because we usually work with complex interventions in implementation science. I'd like also to make some comments and summarize the concept of multi-level interventions. And for that, we can use the social ecological model, which is a model very frequently used in implementation science and very useful. And finally, just mention the multi-sectoral approach proposed by WHO. So let's start with the concept of implementation science. I know that you are familiar with this concept, but let's just review that there are a lot of things that we already know. We have a lot of evidence about a lot of conditions. We, for example, know how to treat hypertension, to treat diabetes, or any other conditions. We know about evidence-based interventions. We have a lot of literature and knowledge about different conditions. I think that someone has the mic open. So I was saying that we have a lot of knowledge really in health, related to health, to different conditions, treatments, how to manage different problems, different health problems, or work within the health system. There is a lot of knowledge there. But the problem is, as you know, that those interventions that we know are effective, evidence-based, that proven effective interventions are not implemented in practice or policies, or it takes such a long time to get there implemented in practice. So the whole idea, the logic underlying the concept of implementation science is to contribute with method, to contribute to bridge this gap between what we know and what we do. This is implementation science. How to get those evidence-based interventions that we know are effective into put into practice. How to do that? How to elaborate, to build, to co-design implementation strategies to make that possible. So, as you already know as well, this is very complex, and complexity is part and parcel of implementation science. If we want to work in implementation science, we have to embrace complexity, because we always work with complex problems. And when I say complex, I mean problems that are affected and caused by different factors, influenced by different variables, problems that have really a great deal of complexity in their, not only in their nature, but only in the solutions that we can propose to solve these health problems in our population. So in implementation science, we always work with problems that are complex. Why this intervention is not applied in practice? Well, there are many factors, always. There are many interacting factors that are, again, complex. Also, we work in a complex context, always. We have rural settings, urban settings, we have different factors related to the context at different levels that can affect the way we implement different strategies. And the context not only is complex, but also dynamic. You know that our contexts change over time, and we have to be aware of those changes and how to adapt the interventions we want to implement to those changes in this complex context. Also, we have complexity in terms of populations, because we deal with and we approach different populations, and there are more vulnerable populations, more difficult to reach populations, different educational levels, different cultures, different settings. So the populations that we work with are also complex. So we are working with complex problems in complex contexts with complex populations, and that's why we need to approach these problems with complex interventions. And in a minute, we will talk about the definition or the concept of complex interventions. What is a complex intervention? And because we always in implementation science design complex interventions, also we have complexities in terms of implementation strategies to make those interventions feasible and acceptable in different contexts. So in this slide, I try to summarize the different sources of complexities that we always have in implementation science. And I mentioned complex interventions. So the next question can be, what makes an intervention complex? What is a complex intervention? And we say that an intervention is complex when it consists of different components, not only one component, but more than one component. For example, if I have to treat hypertension, a hypertensive patient with a pharmacological treatment, the intervention is simple. I mean, we have and we know about a lot of clinical trials, for example, where the intervention is to give the patient a pill, a certain medication, and that's all. This is the whole intervention, the pharmacological treatment that we propose for that patient. That's an example of a simple intervention. In the case of complex interventions, we have different components, not only one, and we will see some examples. We have different components, and frequently those different components take place at different levels. The individual level, the interpersonal social level, the health system level, the policy level. So not only we have different components, but also and frequently those components take place at different levels. Also, we talk about complex intervention because it is very frequent in implementation science that we approach more than one behavior. Coming back to the example of hypertension, we can, for example, work on adherence to medication, but also to increase physical activity, because we know that physical activity is something really important to keep blood pressure levels or values controlled. And we can also work on food habits, improve food. I'm sorry. I'm sorry. Improve food habits for the population. So we can approach. We have a problem which is control hypertension, but we can approach different behaviors to get blood pressure control in this example. And complex interventions that are characterized by these attributes that I am mentioning, more than one component, more than one level, different behaviors, have all of these complex interventions, some characteristics that are important to take into account. For example, since we have different components in our intervention, there is interactions among these components always. We cannot think of these different components as separate interventions. On the contrary, on the opposite side of this conception is this idea of interaction between and synergies between different components. And because of these interactions, what we want to achieve is this concept that the whole effect of the intervention would be greater than the sum of its part, of its components. Always the whole effect of a complex intervention is greater than the sum of the effect of each component of the intervention. So I like this metaphor of a soup. Let's think about a soup, and we, for example, can say that it's really tasty and we like it, but it's impossible to disentangle the different ingredients in this soup and identify the flavor of each of the ingredients in the soup. So in complex intervention, we have the same situation. We have different components, but it's very difficult to disentangle, to separate the individual effect of each part, of each component. And this is key in implementation science, because as you may already know, we always work with complex interventions to approach these complex problems. And one of the characteristics of complex interventions, as I said before, is that frequently the different components that we work with take place at different levels. So we have here the social ecological model, which is really very helpful in implementation science. We can see here that we can think design components at the individual level and the interpersonal, organizational, community, policy level, and the interactions between these components and the synergy between these components would make the intervention more effective if the intervention is, of course, well designed. So let's see an example of how to work with this social ecological model. Coming back to the example of hypertension and how to manage hypertension. So we can think of different components, for example. At the individual level, we can think of counseling. We have experience, and actually, there is a lot of experience, a great deal of experience working with counseling, for example, provided by community health workers or nurses or physicians, primary care physicians. So we can use counseling for patients to help them and empower them to, for example, work on medication adherence or more healthy habits. We can also, at the individual level, work with digital solutions, and there are applications that we can design, and many of them are available and free. Open source, and we can use them free of charge to send text messages to patients to reinforce these counseling on healthy or how to achieve healthier habits, adherence to medication, continuity of care, etc. Also, we can provide patients with blood pressure devices to self-monitor their blood pressure. We know that hypertension and many other chronic conditions are kind of silent. So, for example, in the case of a hypertensive patient, if you don't take your blood pressure, you don't know if it is controlled or not. And this is very important for patients to make it visible, the problem. So self blood pressure monitoring is an intervention evidence-based and really effective. So at the individual level, these are just some examples of the components that we can think of in our complex intervention. What about the family and social support interpersonal level? There are studies that tell us about peer support and peer-to-peer relationship to improve or to help patients to better control their blood pressure. So that's an example of intervention that takes place at the interpersonal social level. We can also think of components of the intervention at the provider level, at the healthcare provider level. For example, we can train the primary care team in team-based approaches to care. Training is very important on different conditions in general. Audit and feedback, for example, and again, peer-to-peer, in this case, among healthcare workers, to work together on how to improve strategies to help patients to better control their hypertension. Those are examples of components or potential components of an intervention at the provider, the healthcare provider level. Then we have the organizational or health system level. For example, we can work with electronic health records, we can work with electronic appointment systems, and also reminders about those appointments to improve continuity of care. All these are examples of potential components of an intervention at the health system level. What about the local community environment level? We, for example, can work with civil society organizations, looking for lay support networks in the community. Also, we talk about healthy habits, but healthy habits need a good environment to make it easier for people to um, to, to achieve these improvements in our healthy habits. For example, we can work on the architecture of the neighborhood, the availability of green spaces so people can increase physical activity. Also, we can work about the availability of healthy food in the neighborhood, etc. Then we can go even higher to the state or province health policy environment. So there are municipality level organizations and networks that we can work with, local initiatives in small or big cities that we can make a partnership with, also to reinforce the care of patients in their own cities. And finally, we can think of the national health policy environment, and here we have policies at the national level or at the state level as well that we can work with the government, and elements such as free access to medication, for example, or working with advocacy with different groups that can make advocacy in favor of policies that benefit hypertensive patients in this case or other conditions. So this is an example of how we use the social ecological model when we design a complex intervention for a given health problem. Of course, we don't need to act or to think of components for all these levels that we can approach within the social ecological model, but we can pick up some of them and include them in our interventions. So this concept is important. We are talking about complexity, and we see complexity from different sources. That's why we design complex interventions. We define complex interventions because they consist of different components at different levels, approaching different behaviors. And we try to summarize all of these using this framework, the social ecological model, that is really useful and important to know if we plan to work in implementation science. And finally, I'd like to share with you, I don't know if you're familiar with this multi-sectoral approach proposed by WHO. You can see in the external part of this figure that WHO proposed that we work on social, political, environmental, commercial determinants of health. So the idea here, the logic behind this model is that when we want to approach a health problem, we don't or shouldn't think also in the healthcare system, but in other very different and multiple sectors that approach these social, political, environmental, commercial determinants of health. It's a very complex and useful model. And I see a hand, Renan. You want to say something?
Yes, we have a question from the chat.
Okay.
Marina asked, is this intervention complexity related with hybrid designs, one, two, and three?
Perfect. That's a very good question. I will try to get back to the definition of a complex intervention. So here, very summarized again, we are trying to describe the the characteristics of a complex intervention. And the problem here is that we can design this intervention, but then we have to test it, we have to demonstrate that this complex intervention is effective, actually. And not only that it is effective because it has a health effect, I mean, in our example about hypertension, we can consider a complex intervention effective if we can lower blood pressure. So if we can achieve control of hypertension, that's effectiveness, that's clinical effectiveness. In other problems, in other health problems, we can think about other indicators of clinical effectiveness. But that's clinical effectiveness, and that's of course very important. Equally important is the implementation effectiveness. I mean, the acceptability, accessibility, adoption, reach, the different characteristics of the implementation of the intervention. So I like very much this question. It's a very important question because in traditional research, what we measure is clinical effectiveness only. And this is typical, for example, of pharmacological trials for any condition. We measure effectiveness, clinical effectiveness only. But the problem is, as we said at the beginning of this talk, that these interventions that are evidence-based then are not translated into practice. So what about implementation? We need indications, we need to measure the implementation of these interventions. We need to measure the context, the adoption, the acceptability, etc. Those are implementation outcomes, different to clinical outcomes. And to evaluate both outcomes, clinical and implementation outcomes, we use what we call hybrid designs. So it's a very good question. In traditional research, we use different designs, as you know, but in implementation science, we use hybrid designs, and we call them hybrid because they evaluate at the same time clinical effectiveness and implementation outcomes, both things at the same time. That's why we call them hybrid designs. And as you said, there are three types of hybrid designs: 1, 2, and 3. In hybrid type 1, the primary outcome, the primary focus, the primary aim of the study is to measure clinical effectiveness, because maybe we still don't have enough evidence about the intervention. So the primary aim is to measure clinical effectiveness, blood pressure in our example. And the secondary aim is measuring, or is related to measuring implementation outcomes, acceptability, feasibility, etc. That's a type 1 hybrid design. In type 3 is the opposite. We have a lot of evidence about the interventions we want to apply, so the primary outcome, the primary aim, is measure implementation, feasibility, acceptability, etc. And the secondary aim is connected with measuring clinical effectiveness. Because of course we always, in all these studies, we measure clinical effectiveness because at the end of the day that's important. I want, in our example, to lower blood pressure, so I measure that. But since I have a lot of evidence about the effectiveness, the clinical effectiveness of the intervention, my main questions to answer are implementation questions, are related to acceptability, feasibility, adoption, etc. So in a type 3 hybrid design, The primary aim is measuring implementation outcomes, and as a secondary aim, we measure clinical effectiveness. So we have type 1 and type 3, and type 2 hybrid designs are in the middle. So we say that in type 2 we have co-primary aims at the same level of importance, at the same level of relevance or hierarchy. We measure both clinical effectiveness and implementation effectiveness. We are in the middle between these two extremes of type 1 and type 3. I don't know if it is clearer now. You can tell me.
For me, it's really clear. I don't know if for Marina. Yes, very
Marina,
clear.
is it
Yes.
clear? Okay, great, great. And your question, Marina, is very important because sometimes there is this confusion between study designs. You know that we have different types of study designs. We can conduct a clinical trial, a randomized controlled trial. We can conduct observational studies, economic evaluations, cross-sectional studies. Those are examples of study designs that we are very much familiar with, even in traditional research. But when we talk, about hybrid designs, are specific to implementation science. And the difference between 1, 2, and 3 is not the study design. It can be a trial, it can be a quasi-experimental design, it can be an observational design, etc. That's not what makes the difference between hybrid 1, 2, and 3. The difference between hybrid 1, 2, and 3 is the hierarchy, the importance of the aims. So again, the primary aim in a type 1 is still clinical effectiveness. As a secondary aim, we measure implementation. In a type 3, the primary aim is implementation, definitely. And as a secondary aim, we measure clinical effectiveness, and type 2 is in the middle, and we have co-primary aims. Both clinical and implementation outcomes are at the same level of importance. So I can choose between 1, 2, and 3 according to basically the level of evidence, the degree of evidence that we already have or don't have on the intervention that we want to apply. That's the decision between 1, 2, and 3. And the name hybrid is related again to this concept of measuring at the same time clinical outcomes and implementation outcomes. So it's an important question. And here I think that Gisela is writing a comment in the chat, but I cannot understand.
Don't
It's
worry, Vilma. It's
just a
just
comment.
yes, just a comment about the organization of the event. A student asked me for you to speak a little bit louder, if it's possible for you.
Okay, yes, sure.
I think now it's better.
Oh, oh. Should I start again with?
No, we will continue. Thank you.
Okay, okay. Well, great that you bring to the table the concept of hybrid designs because they are specific to implementation science and are really important. It's not a topic for this talk, but they are really important. So, as a summary, let me go maybe again through these main concepts, and I, of course, we can throw it open to questions. We have the concept of implementation science as the science to contribute, or with the main objective of contributing to bridge this gap between the evidence we know and what we do in practice and policies. We have to embrace complexity if we want to work in implementation science, because there is complexity in the type of problems, context, populations, interventions, and implementations that we will work with always. We defined a complex intervention talking about more than one component, level, and behaviors, and we mentioned these characteristics of synergies and interactions between the different components of the intervention, and the importance of the social ecological model that help us design interventions with components at different levels. As an example, we talked about hypertension, but of course we can apply this model to different conditions. And finally, I'd recommend to go more in depth. We don't have time today, but to go more in depth into this multi-sectoral approach proposed by WHO on social, political, environmental, commercial. I'd like to highlight commercial determinants of health, because we live in a complex world, and there are implications for any solution that we try to test, to apply to different health conditions. So, to me, this is the first part, let's say, of the talk. And as I said before, let's throw it open to questions or comments from the audience. Maybe you have experience, or you want to share with us studies that you are designing or thinking of before the break, if you agree.
Any questions?
Vilma, just for you to know, to have an overview, we have different students here from different areas, different types of research, and we have people from implementation science and others with research in the lab or clinical studies. So we have some professors from our department here, and I don't know, I think we have some questions. Someone open the camera, the web.
Hi,
G.
Vilma. Yeah, nice to meet you. My name is Gisela. I'm a professor, assistant professor at Unicid. And I'm thinking about how is the implementation process in your country? Because here you have some steps first to minimize this gap between the science and the implementation of the interventions. And I'd like to know, how is this process in Argentina?
I like your question, Gisela, because you know that first you mentioned this process, of going from what we know to practice. And although I tried to draw this bridge, in the slide, I actually think that there are many bridges, there are many steps. It is not one bridge that we have to cross. In my opinion, there are several bridges that we have to cross to actually achieve really effective implementation in our populations. And you asked me about Argentina, and I'd like to answer your comment talking about our region, our Latin America region. We have a lot of problems in common. We are very similar. We have differences in terms of the population or the organization of the health system. For example, at the moment we are working together with colleagues from Brazil, actually, from Peru, from Colombia and Chile, Argentina, Guatemala. And I can tell you, Gisela, that there are a lot of communalities among us. I think that we have to, it would be great if we can learn from each other and, about the solutions that we find, because really we are fighting similar problems and similar situations. So I don't think that it's very different Argentina from Brazil, actually, and I talk a lot with my colleagues in Brazil. But something that I think is common to all our region, Latin American region, is that we should work together and in collaboration more often, because I think that that's the way that we can find solutions that then we can apply and adapt to other contexts. In Argentina, there are at the moment, and in my institution, a lot of implementation science projects on different topics: mother and child, chronic conditions, infection diseases, and each one of them is different in terms of the implementation strategies that we use, really. But to me, the rich part of this work, of this job that I have as a researcher, is to learn from my colleagues from other countries in the region, really. And I think that that's the future, to work more in collaboration. That's at least my view on the topic.
Yeah, thank you, Vilma. Yeah,
Thank you.
because Marina has a work with implementation of telerehabilitation and using education intervention. And she started to implement this in a public health system in Brazil, in a small city, but now the plan is extended for all state and after maybe in the country. Yeah, that's the reason that she asked you about the studies, because she's conducting hybrid design here in Brazil.
That's great. That's great. And in general, talking about process more concretely, in general, we start with a feasibility study, a very small study just to refine, and tailor these implementation strategies that we co-design with different stakeholders. And so we start small, and then in general, we go into a hybrid, maybe working in several cities or towns or whatever, and then we go into scaling up. It's a process, as you said, it is sequential, and you learn in that process, because it's very difficult to work at a small scale, in a feasibility study, but you learn a lot from that experience, always, at least in my experience. And then when you go at a scale, we have other problems, other kind of difficulties and complexities, and you work on that. But you don't start from scratch. You have experience, you have these small experiences from which you learned already. So there is, in my view, kind of a ladder, from small studies to scaling up at a bigger scale, and this is a process. And I think that it's very important to take care of that process. I don't think that we can go into big scale, just at the beginning of our ideas on implementation science. I don't think that that's a good idea, really.
Yeah, that's why Brazil, you need to have a lot of financial support to conduct large studies. Yeah, and then now you are trying to conduct the small ones and go to the complex studies after. So thanks so much, Vilma, for your
That's
view.
a That's a great comment. That's a great comment that has to do, has to do with funding, because of course we need funding to conduct these studies. And for instance, in Argentina, we don't have national or local funding really. It's very small. It's very small. So we apply to international funders, international agencies like NIH in the US, IDRC in Canada, in UK, NIHR, MRC, different federal agencies that can, Wellcome Trust, that can help us, get this funding to conduct these studies. So if you have a preliminary small study, that makes for sure your application stronger. You in Brazil, and I'm of course not an expert, but I think that you have more national funding than, I mean, compared to Argentina. For example, I know about FAPESP and important agencies in your country that you can, approach for funding.
Yes, we have. Marina?
Good afternoon. Hello. Sorry
Hello.
about my English.
Sorry
Gisela,
about
help me.
English as well.
I'd like to know about randomized clinical trial in implementation science. I wonder, we are testing different types of delivering the intervention. And I wonder if, considering the user's preference for the modality, would be better than randomizing. I'd like to know about that.
That's a so good question. I have a long answer and a short answer for that. So let me go for a short answer. And in general, in implementation science, we work a lot with the end user, whatever the end user is, the patient, the community health worker, whatever the end user of the intervention is. We work a lot on the design phase of the intervention. So we call it co-design, right? So we co-design the intervention taking into account the preference of the end users. Then when we go into the field, usually we work with clinical trials, but randomized clinical trials, but in general, these are not individual randomized control trials, but cluster randomized control trials. So we randomize clusters. Those clusters can be, for example, primary care centers. We randomize these primary care centers to work with the intervention and these primary care centers to be the control, usual care, for example. So we use a lot randomized control trials, but they are cluster randomized control trials. So we can work, in the natural environment where people receive care. So we do that. And always take into account the user perspective, but especially during the co-design process more than during the intervention itself. There is a very interesting concept. We don't have time maybe today to talk about that, but maybe you are familiar already with this, and the concept of adaptive trials. It's so interesting because we can work methodologically with adaptive trials. So we can include preferences within the design of the trial and randomized not just once, which is traditionally or the traditional way of randomization, right? I'm at the beginning of the study randomize the centers, to be part of the intervention or the control group, and then we follow up them over time. But in adaptive trials, we do a first randomization, we test the preferences of the users, and we randomized again, maybe 2, 3 or 4 phases. So this is the way we can include preferences in a very rigorous methodological approach conducting the trial. The concept is adaptive trials. It's very, very interesting. We don't have today to talk about adaptive trials, but I can share with you, maybe I can share with you, Rafaela and Renan, a literature or references about that. There are several types of adaptive trials. For instance, LAGO, which means learn as you go, or MOST. There are different names for different strategies. It's very interesting. It's a very advanced topic in implementation science, but it's related to your question about taking into account preferences even during the trial. We do that always during the co-design process, but during the trial, it's more difficult. So we have these adaptive trials to do that. And we can talk for hours about your question, I tell you.
Vilma, you can share with us the material and we send for the group.
Perfect, perfect. I can share some really interesting references. Some of them explain in very much detail, some of them are more general, just to introduce yourself, into a topic. But it's very important. And today, for instance, at the time, we are conducting 2 adaptive trials in different provinces in Argentina, and it's a challenge. It's not so easy as in the paper.
It's never is so easy as in the
It
paper.
never is, of course. It never is. Yes, I agree.
Vilma, I think we can have 5 minutes just for a coffee or a water, and we can return at in 5 minutes, in 2:05.
2:05. Perfect. Because we have at the same time. I mean, in
Yeah.
Buenos Aires. So 2:05.
Yes, all
Okay.
right.
Sure.
Great.
Thank you.
Great.
Thank you.
Thank you. Thank you.
So I think we can start again. If everybody take their coffee.
Well, can you hear me better now?
Yes,
Yes,
it sounds very good.
it's clear now.
Good, that's good. I was trying to fix this mic. Well, so we have kind of 40 minutes from now. So I prepare a brief summary of this great topic in implementation science, you already know, which is TMF, theories, models, and frameworks, the core of implementation science. So let's go together through this topic, and please again interrupt me or tell me if you have questions or comments. So let me share my screen. This is our part 2 of the afternoon. And the idea is building on the concept of complexity we have already talked about, introduce the topic of theories, models, and frameworks in connection with what I like to call the 3 pillars of implementation science. Maybe there are more pillars, but I think there are 3 very important. So first concept, as many of you are very much familiar with, implementation science relies on theories, models, and frameworks. And what are these tools that we need so much? The first thing that we need in implementation science is to understand and identify mechanisms of change. So, if we want to bridge this gap, if we want to design implementation strategies to make it possible to put in practice the evidence we have, we need to understand the problem. We need to understand the needs, the pathways. What are the mechanisms of change? If I provide counseling and an appointment system and reminders for appointments and peer-to-peer support, if I do these things, if I plan these different components of my intervention, what would be the mechanism of change? Why all these components would contribute to lower blood pressure in our example? So for that, for understanding mechanisms of change, we need a theory of change. Always, always, always. We plan our study, we plan our project, and we need to work on a theory of change. So we know from that theory what are the components that we need, what or which of them can be more important, how to implement them. So we need this theory of change always to design the complex intervention. That's the first tool, the first thing that we need. The second thing that we need is to guide. We need a guide, we need a map for the whole process of implementation. What are the steps? What should I do first? Who, where, when, etc. What are the steps I should follow to implement in the best way possible to achieve the best results possible as well? So the second thing that we need is this map, this guide, and we call it a process model. That's the second tool that we need. So once we have our theory of change and we design our complex intervention, Then we need a map because of the complexity we were talking about. We have to take care of many different things at the same time. So we need this map of different activities and who is responsible for each activity and when should we do this or that or in what way. So we call those tools process models. And finally, of course, as in any project, any program, any research study that we conduct, we need to evaluate what happened, what are the results, the outcomes. And in implementation science, we measure both process and outcome indicators. So not only the final result of the intervention, but also what happened in the middle during all the process of implementation. Again, because of the complexity of the concepts that we work with and that we want to measure, again, we need a framework with different dimensions. So we are sure that we are measuring all the results and processes that we need to first to know if the intervention is successful, then if it is scalable, as we were talking a few minutes ago, etc. So for that, we need an evaluation framework. These are the three main tools that we always need in every implementation science process. At least a theory of change, a process model, and an evaluation framework. And something that is common to these theories, models, and frameworks is that all of them take into account these three pillars. I call it pillars of implementation science, which are number one, a meaningful stakeholder engagement. Always the stakeholder involvement and engagement is key in implementation science. We were talking about user-centered designs. Well, users are important stakeholders for us, but there are many others at different levels in the government, in the neighborhood, at the organization where we work, etc. The second pillar is assessing and understanding context. We always start by studying the context where we plan to work. And finally, the co-design and test of the implementation strategies that we plan to apply in the field. So these are the three pillars of implementation science, and all these theories, models, and frameworks that are available take into account all of them. So now, in this brief time that we have, if you like, if you agree, we can just give some examples of a theory of change, a process model, and an evaluation framework. There are a lot of them. You know that even people who start researchers who start working in implementation science sometimes feel kind of overwhelmed with a great number, a high number of theories, models, and frameworks, and I have to choose from them what are the ones that I will use in my study. There are a lot of them. So today we just will go through one example of a theory of change, one example of a process model, and one example of an evaluation framework. But let me emphasize that there are a lot of them. So let's start with a theory of change. And I chose this theory of change, which is called COM-B. In COM-B, the C is for capabilities, the O is for opportunities, the M stands for motivation, and B is for behavior. So according to this model, to change a behavior, you need capabilities, opportunities, and motivation. These three elements which interact among them will help us change a given behavior. So to give some examples, let's say something about capabilities. For example, you can think or understand from your previous studies, your needs assessments, etc., that there is a problem of knowledge. Let's come back to the example of hypertension. Maybe people is not adherent to medication because they don't have enough knowledge about their health problem. So if you think that there is a problem connected with knowledge, well, education strategies are very useful. Also, you can understand that there is a problem of skills, lack of skills at the primary care team to deal with hypertension or diabetes or whatever the health problem is. So training the team, the healthcare team, it's important to approach that problem. Another example is that we know that physicians in general, we have in general lack of time or very short time. You know, a lot of patients, short time, making decisions can be challenging on the treatment that we recommend. And also, there are many factors influencing. There are many clinical guidelines, for example. We all know very long and complicated clinical guidelines that is difficult to know by heart, you know, or to consult in an easy way. So if it is a problem about decision making and how to help healthcare professionals to make better decisions, we can design decision making tools that can help us make those better decisions for patients and share those decisions with patients. So, for example, at the moment in Argentina, we are conducting a trial where we are testing a CDS, a clinical decision support system, which is an application, a digital solution for primary care physicians to decide on more easily on what is the best strategy to help patients with high cardiovascular risk. And there are many examples of that. But I just liked to bring here some examples of different types of capabilities that you can need to solve or contribute to solve a problem, and you can work on that. The other component, the other dimension of this theory of change is opportunities. And when we talk about opportunities within this theory of change, we talk about the built environment, for example. So what is the access that people have to healthy foods, to give an example, or to green spaces, to walk more, etc. So, for example, look at this beautiful grocery store where you can see different vegetables and fruits here, which are arranged to increase visibility, to make them more attractive, easier access, a lot of variety to choose from, more salience of these fruits and vegetables among other products in the supermarket. So these are strategies that we can use to work on the environment to make it easier for people, for all of us, to make healthier choices. This is an example of how to work on the built environment and the access to those things that we need to change our behaviors. But when we talk about opportunities, we don't talk only about the built environment, but also about the social environment. For example, publicity or communication campaigns to make people more aware and conscious of the importance of certain behaviors, and also, of course, policies and regulations and the importance of different of politics that can lead the country or the region or the subnational levels as well. So those are part of the environment, built environment, social environment, political environment that we can work on in terms of generating more opportunities to change, for example, a given behavior. And when we talk about motivation, in this theory of change, we talk about intrinsic motivation, for example, more confidence, more visibility of our achievements, and also extrinsic motivation that is connected with incentives, using incentives, both financial and non-financial incentives. So just a brief overview of an example of a theory of change that, as you can see, can help us design different components of the intervention. This is a combi theory. It's very commonly used, but there are a lot of other theories as well. So let's go now into an example of a process model, this map that we need to organize our work. So this process model is called EPIs and work with different aspects of problem solving orientations, and it is composed or it proposes 4 different stages. First, exploration of the problem, then preparation, then implementation, then sustainment. That's it. This is the EPIS model for implementation. And in each of these domains, exploration, preparation, implementation, sustainment, there are a lot of activities proposed that really help us on how to organize our work. On the top right of this slide, you can see the web page where there is a lot of information about this model and a lot of detail that we won't go through today. And again, aside from EPIs, there are a lot of other process models that we can choose from as well. And finally, let's see an example of an evaluation framework, how to evaluate these interventions that we are testing. And this is one of the most commonly used frameworks, the REAIM framework. I'm sure that many of you are familiar with this one or have used this one. Again, there are others. But in the case of the REAIM framework, we have 5 different dimensions: reach, effectiveness, adoption, implementation, and maintenance. In the case of reach, the question is if I really can reach those who need the program, the practice, the policy we are testing, the intervention we are testing. So to measure the level of reach of our project, we have different indicators, and I wrote here some examples. For example, the number of people that is using or that is receiving the intervention, but not only the whole number, the entire number, but the distribution in different subgroups. That's very important, because sometimes we can implement an intervention very successfully in a certain population, but not in other populations. So we can have a problem reaching more, for example, vulnerable or more marginalized populations. And this is very much related to equity in implementation science. So when we talk about different subgroups, we talk about gender and age and education and so forth. Also, the representativeness of the people included in our studies. When we test these interventions, equity is always here present, and we can talk a lot about indicators of reach, but these are some examples only. Then we have effectiveness. So the question here is if the program is effective, and we measure both positive and negative health outcomes. We have to have in mind that there might be unintended consequences of our programs or projects or interventions. So we have to be careful and not only measure positive effects, but also negative unintended effects. Patient-centered outcomes, that's PCO, patient or user-centered outcomes. Cost effectiveness of the intervention is important here as part of the effectiveness as well. So some examples of indicators that we refer to when we talk about effectiveness. Then we have adoption. What is the degree of uptake of the intervention program policy that we are proposing? So in this case, we measure, for example, the proportion of implementers that adopt the intervention and actually put it in practice. And what are the characteristics of those implementers? For example, is this intervention adopted easily or more easily by young members of the primary care team or more experienced members of the primary care team if the intervention is at the primary care level, of course. So we can, or maybe there are factors like gender or years of experience, places of work. The idea here is to measure the degree of uptake, adoption of the program or intervention, but also to identify different characteristics that can help us differentiate early, for example, and late adopters, or even people who is resistant and reluctant to adopt the intervention we are proposing. So this is an important part of the evaluation process in implementation science. Then we have implementation, the actual implementation. How is the program actually implemented in reality? And here we have the concept of fidelity versus adaptation. Maybe you are already familiar with the concept of fidelity of implementation. We say that fidelity of implementation is the degree to which the program or practice or intervention is implemented according to plan, according to protocol. So the degree of compliance with the different components that we propose, that's the fidelity of the intervention. The other side of the coin is adaptations. And this is another big topic in implementation science. We don't have time today to talk about adaptations, but there is always this tension between fidelity to the proposed plan at the beginning of the study and adaptations that might be necessary during implementation. There is a lot of things to talk about adaptation. We don't have much time today, but again, I can share references on the different types and reasons for adaptations in implementation science. There are always adaptations, let me say that. So we measure implementation fidelity, for example, by measuring what we call those delivered and those received. For example, if a component of the intervention has to do with sending text messages, and we plan to send one text message per week during a certain period of time, we can measure if those messages were actually sent, or we have some technical problems for that. That happens, of course, in practice. And also if the patient or the participant actually received or even read those messages. Those are examples of indicators of fidelity. And the same for each component of the intervention. And finally, maintenance or sustainability of the intervention tells us about how much the program, the policy, the intervention, and its benefits are sustained over time. So we need to measure this, and I would say that this is the most difficult dimension to measure, frequently because of limitations in terms of funding. Suppose that we conduct this beautiful hybrid study, and it is a cluster randomized controlled trial. We measured implementation outcomes and clinical effectiveness outcomes, and the intervention is really successful, and we publish that, etc. Once the project is over, the research project is over, it's very important to know what happened in reality. Is it, the practice that we proposed and that was so successful has sustainability and continuity over time or not? So that's something that we are very much interested in measuring, and sometimes it's difficult really to measure this sustainability of the interventions because this needs time, requires time, and frequently we don't have enough funding to measure this continuity of the interventions over time. So, for example, the degree of institutionalization is important. If the institution says, well, yes, this study tells me that this way of working, of approaching, of managing patients with this condition is effective, is useful, is acceptable for people, is feasible, etc., I would make it a regular, usual practice in my institution. So that's very important. That's a buy-in from the people who actually can make decisions over different interventions that we test. Maybe they are incorporated into guidelines, national guidelines, for example. Those are things that can contribute to sustainability of the interventions that we test beyond the research study. Long-term policies, those are the kind of indicators that we'd like to know about the different projects that we conduct in implementation science. But as I said before, sometimes it's the most difficult dimension to measure. So, well, if you agree, I will stop here and listen to you. I see Marcos' hand here.
Yes, can you hear me?
Yes, perfect.
Okay, first of all, sorry for my bad English.
No,
But
no,
the
sorry.
thing is, you said that there's a lot of different frameworks and models to work with. And I also know different models like the theoretical domains framework. I don't know if you're familiar with it, and the behavior changing wheel, etc. I mean, there's a lot of them. And my question is, what is this choice based on? I mean, what aspects should I consider to choose between the different models? Does this question make sense at all? I mean,
That your question, Marcos, is the 1 million question, you know? If I mean, if I'd have the answer, I think I would be rich, really. But
yeah.
it's it's a complicated question, really, because as you say, there are so many theories, models, and frameworks that we can feel really overwhelmed and say, well, what are the factors that I should take into account to choose from them, you know, and say, well, for my project, this is better, this framework is better than this another one, or things like that. So I'd say something that is good and positive for us researchers is that there are a lot of overlap between them, you know, a lot of overlap. So that's something really nice to know, because maybe you choose this framework and I choose this another framework, but there is a lot of overlap between them. So it's not so different, you know, to use one or the other. And that's a reality. To be honest, that's a reality. They are not so different, really. So that's something positive for us, I would say. That's the first reflection on your question. The other reflection is that, as for almost everything in research, I think the one you are more familiar with is the best for you. For instance, you start working with a team that is very much familiar with the theoretical framework and the wheel and combi, etc., and they have a lot of experience working with that, and you join that team. So that's the best option for sure for you, you know, before maybe starting exploring other options. So familiarity with certain frameworks, I think that helps. And the third reflection that I'd like to comment in relation to your question is that sometimes when you start exploring different frameworks, you find that some of them are more or put more focus on some aspects. And so if you are more interested in those aspects, that's a framework you should choose, you know? And sometimes that we very much frequently do is to use more than one framework. For example, in one of the projects that we are conducting at the moment, we are using a generic framework. All these frameworks that I was talking about today are generic frameworks, meaning that they can be applied to different health problems or situations. But also there are specific frameworks that we can add to your generic framework, so you can go more in depth on something that you are very much interested in. And in these examples that are coming to my head now, we are using a generic framework for a project, but because we are very much interested in gender and gender equity, we complemented this generic framework with a gender perspective framework developed by the Hopkins University, for example, in this case. So we have all the information of the different theories, frameworks that we chose, plus this specific framework on gender diversity, because the project is much more about that. There are specific frameworks also if you are interested in digital solutions, because digital solutions have some aspects that we have to take into account, and maybe they are not completely covered by these generic frameworks. So we choose one generic and we complement that with a specific framework for digital solutions. So that's the way we work. I think that there is no, one answer for your question, but those are my reflections. And they
Yeah,
will work.
now I have another question.
Okay.
The
Great.
thing is, I love the reflections because I've worked with more than one model. I've worked with the APIS model before, and I've worked with the TDF, and
Yeah.
both of them seems equally comprehensive, you know?
Yes.
So they overlap each other, like you said. But so it makes sense, the reflection you made. But now you said something that got my attention. There was the digital solutions model. Do you have any examples for it?
Sure, sure. I have examples of almost everything, Marcos. I have the examples. Then to use them, as Renan said, to use them in practice, that's another thing. But I have the frameworks, so I can share references on adaptive. I wrote here, took my notes, to send you references about adaptive trials, and also I can send you on digital frameworks as well. I like a lot one, which is, and we are using it, which is called ACT, ACT. It was developed by David Moore, an US researcher. I don't remember from which university, don't remember that. And I can send you the original article about the development of the framework.
Yes.
It's very, very, very useful. And there are others, there are others. For example, WHO has delivered a very nice framework for digital solutions as well. There are
Thank
frameworks for, no, thank you for your question. There are frameworks for if you are working with adolescents, for example. You have a whole world there, and there are a lot of specific frameworks for that as well. But yes, I have kind of a library.
Please share with us.
My pleasure to share with you.
Unfortunately, I think we don't have much time just for a short question. If anyone else? No, I think it's no. So thank you so much, Vilma. Your I don't know how to describe this. Is very very interesting. It's like I think I I'm out of here with my more question than I entered, but it's a big pleasure to hear from you.
It's a big pleasure for me. I wish you the best of luck with your research and your careers. Honestly, the best of luck for you. And I hope, first, that we meet in person sometime. I'd like more the in-person, interaction. So maybe sometime we can do that. And the second thing that I would love really is to collaborate together in some projects in the future. So you have my details, my emails, and you have Renan and Rafaela, they can contact me as well. I will share these materials, and if you have any other questions or maybe recommendations, readings or whatever, just tell me. It will be my pleasure to share what I have with you. So best of luck, and thank you very much for your time today.
Thank you so much, Vilma.
Thank
Thank
you,
See you
Vilma.
soon
See
Thank
you
you.
soon.
in
See
person.
you soon. See you soon. Obrigada. I only know to say obrigada.
Yeah,
Uh,
That's my first
yeah.
word, not the last. My first word in Portuguese.
thank
See
you
you
so
soon.
much.
See you soon.
See you
Bye-bye.
soon. Bye
Bye.
bye.
Bye.